Hi, everyone. Welcome back to Can't Touch This, Exploring the World of Surface Cleaning virtual conference. I'm Adam Okada with Beyond Clean. I'd like to give a special thanks to our event sponsor, 3M, for supporting today's educational event. It's their dedication to your education that made today's event possible. Jacqueline Daly, sponsored by 3M, is a senior infection prevention manager with over 35 years of experience in infection prevention industry. She's a well-known industry presenter with experience presenting at local, national, and international conferences and meetings. Jackie has published many articles on the prevention of surgical site infections, and her articles have been published in Isham's Process magazine. She's a member of the Association for the Advancement of Medical Instrumentation, and she serves as the sub-vice chair for the Biological Hazard Subcommittee. Today, Jackie is going to discuss the regulatory requirements for environmental cleanliness and the various products used to properly disinfect environmental surfaces in the healthcare setting. She will also explain the role healthcare environments play in disease formation and transmission. So are you ready to discover how clean is clean? Let's welcome in Jackie.
Good morning, everyone. Welcome to the Beyond Clean Can't Touch This conference. My name is Jackie Daly, and I will be speaking today on environmental contamination and environmental cleaning, how clean is clean. Thanks very much for joining us today. We will move through to the next to show you that the disclaimer here, that the content standards and guidelines are as official as of June 11th today. And again, for anything that requires manufacturer's instructions, make sure that you consult those and follow your local laws and regulation. Here are my disclosures for you here. Today, we are going to look at a few objectives. The first, we will discuss the regulatory requirements for environmental cleanliness. And there are a few that are involved there, so we will touch base with a couple of those that directly impact our practices in healthcare. Explain the role of the environment in disease transmission, especially after, I shouldn't say after, during this pandemic, where the environment was a key focus as well. And then discuss some of the products that are used to disinfect the environmental surfaces. And then we'll talk about some methods that can be used to verify environmental cleanliness. For the first objectives that we will cover, are the regulatory and accreditation agencies' expectations, and also that our patients that we serve in healthcare are expecting more as they become more informed and more educated. The Center for Medicare and Medicaid puts out for healthcare facilities conditions of participation, and the one that I am brought forth here is on infection control, where they expect hospitals to provide a sanitary environment, avoid sources and transmissions of infections and communicable diseases. And that there is a requirement for an active program for the prevention, control, and investigation of infections and communicable diseases. So the bottom line here is that we are to provide sanitary, clean environment with appropriate monitoring of housekeeping and maintenance and other activities to ensure the sanitary environment. And this has become an expectation not only from the agencies that accredit, but also from our patients. The conditions of participation are quite implicit when it comes to what we need to do as a hospital or other healthcare facility with maintaining that sanitary environment. The techniques for cleaning and disinfecting are quite important, not only high-touch surfaces, but also other carpeting, furniture, and there should be means of mitigating the risk that contribute to healthcare-associated infections. We also need to be conducting active surveillance with methods that are in place for monitoring and evaluating practices, and monitoring also compliance with the policies and procedures and other requirements of our infection prevention and control programs. Some of the accrediting bodies that are referenced here, the Joint Commission, requires that we implement our infection prevention and control activities when it comes to cleaning and performing low-level disinfection of medical equipment, devices, and supplies. Then we have the DNV that requires that organizations shall provide for and maintain sanitary environment to avoid the sources and transmission of infections and communicable disease. And you see that this organization also, along with the Joint Commission, falls in line with expectations of CMS. AAHC, which is the ambulatory accrediting agency, expects that the healthcare organization, the healthcare facility, has written policies that address the cleaning of patient treatment and care areas, and also requires that at a minimum, policies address cleaning between patients, cleaning before use, terminal cleaning, and the frequency based upon the area. Using cleaning products according to the manufacturer's instructions for use, and those instructions for use must be the most recent copy. So again, the Joint Commission and the DNV are in line with the CMS as well as the AAHC. There are also regulations and evidence-based guidelines that impacts how we maintain that sanitary environment. We have the Center for Disease Control and Prevention, the Association for Professionals in Infection Control and Epidemiology, APIC, the Society for Healthcare Epidemiology of America, SHE, the Association of Perioperative Registered Nurses, the AORN, and Occupational Health and Safety Administration, OSHA. But please be reminded that OSHA is your federal regulations, but your state OSHA may also have more strict requirements than the federal regulations. So let's move on to our second objective, which is to explain the role of the environment in disease transmission. With the number of multi-drug resistant organisms that are now being identified and are impacting our practices in the healthcare environment, I say that the bugs are turning up the heat. In 2019, the CDC published their antibiotic resistant threats in the United States. Now, this document is 150 pages as compared to the previously published document in 2013, which was 114 pages. And this new edition emphasizes that antibiotic resistance is one health issue that can spread through people, animals, and the environment, threatens our most vulnerable populations, friends and family, and affects nearly every aspect of life. This report, however, does not address the viruses, but addresses only the bacteria. And it also goes into the challenges around the spread of germs from the healthcare environment, which is the main focus of my talk today. such as the bed rails, devices, and other surfaces, and that we require continued vigilance against serious threats like carbapenemase-resistant enterobacteriaceae, or what we call CRE. We also need to be a little bit more consistent in the way we implement some of these recommendations that are provided through the CDC to ensure that we are doing everything in our power to reduce the risk of transmission of these antibiotic-resistant organisms. One of the things that CDC wants to emphasize is that we stop referring to the coming post-antibiotic era, because it's already here. We have our urgent and serious threat organisms, and you can see them listed there for you. We have a number of carbapenem-resistant organisms, Acinetobacter and other Enterobacteriaceae organisms. We now have a new yeast, Candida auris, that was just recognized. Clostridioides difficile, previously known as Clostridium difficile. And now we have drug-resistant Neisseria gonorrhea, which is not really an issue for healthcare, but it is now and has made the list of urgent threats. The serious threats organisms are also listed there for you. Again, we have our drug-resistant Candida, which are other ones other than Candida auris, our ESBL-producing organisms, vancomycin-resistant Enterococci, Pseudomonas aeruginosa. We're all familiar with MRSA, methicillin-resistant Staphylococcus aureus, but we've also got resistant Streptococcus pneumonia, which is a common cause of community-acquired pneumonia, and drug-resistant tuberculosis. And just to emphasize that tuberculosis has not gone away, it is still there, but now we are seeing more resistant organisms from that family of organisms. And what 2020 has showed us is that we also need to be highly aware of emerging novel viruses such as the SARS-CoV-2 and what its impact that was realized on the environment during this pandemic, as it is ongoing as well. During the pandemic, we've had to implement enhanced infection prevention measures, but we should not be limiting these enhanced measures just to outbreaks, because what this pandemic has showed us is that we need to really step up our game with our compliance with best practices for implementing them and sticking to them with environmental cleanliness. As well, during this pandemic, we've seen an increase in healthcare-associated infections, not only around central line-associated bloodstream infection, CLABSI, and catheter-associated urinary tract infection, SCOTY, but we're also seeing infections in this group with multi-drug resistant organisms in patients that were infected with COVID-19. During the pandemic, we've increased and changed the way we use personal protective equipment. We were doing extended use. We were double and triple gloving in some situations. And that posed a challenge because it was reducing hand hygiene. And then those same hands, if they were not properly cleaned when these items were removed, then they could contaminate the environment. And because of the pandemic as well, we were cohorting patient care. We created cohorted patient care units, and we had patients who were in these rooms for days and weeks on end due to their disease state. And fear was a classic syndrome of this pandemic, where our EVS staff and others were a little hesitant to enter these rooms. They enter the rooms less than would normally have expected. And also we had challenges with our disinfectants. And so now that we are sort of heading back to pre-pandemic status, I am hoping that what we have learned during this pandemic now becomes a routine part of our practices, where we use disinfectants per the manufacturer's instructions and are doing a better job of cleaning verification. There's a quote that I really like. This is from Philip Carlin et al. In a publication, Prevention of Healthcare Associated Infection as it relates to the environment. Epidemiologic studies have shown that patients admitted to rooms previously occupied by individuals infected or colonized with MRSA, VRE, or Acinetobacter baumannii are at significant risk of acquiring these organisms from previously contaminated environmental sites. Now, the reason I think this is important to realize is that if we are not doing proper cleaning and disinfection, and I highlight the cleaning because you cannot disinfect unless you properly clean a surface and a piece of equipment. So when we refer to cleaning, we also need to be thinking disinfection as well. And that the impact of these practices of cleaning and disinfection and doing it thoroughly impacts the environment for when the next patient is admitted to that room. This is a standard in infection prevention. We call it breaking the chain of infection. And that chain is made up of the infectious agent, the reservoir, the portal of exit, the mode of transmission, portal of entry, and the susceptible host. There's things we can and can't control when it comes to the chain of infection. Again, the agent is there, but what we can do is reduce the agent in the reservoir. And that reservoir could be a surface. So again, we need to be focused on eliminating that reservoir. The portal of exit and entry are related to the patient, but if we are doing proper hand hygiene and so on, not only as the healthcare worker, but also as the patient, encouraging that, we might be able to manage the entry of organisms into the body, and also the management of devices that could become contaminated and enter the body. But the two areas of focus for this talk today is to eliminate the reservoir and to interrupt the mode of transmission. There are a number of strategies that have been used to prevent healthcare-associated infections, such as using dedicated patient care equipment for patients with multi-drug resistant organisms, and the use of standard and transmission-based precautions requiring the use of personal protective equipment, gown and gloves based on a risk assessment as to what would be contaminated on your person, the use of private rooms, realizing that not all facilities are able to provide private rooms, so we need to be looking at how would we manage those environments. We use hand hygiene, alcohol-based hand rubs, soap and water scrubbing for at least 20 seconds, environmental surface and equipment cleaning and disinfection, which again is the focus for the talk today, and providing education to healthcare workers, no matter what setting they're in, whether it's ambulatory, an office, a clinic. We also need to be emphasizing the importance of cleaning and disinfecting of the environment with your environmental services personnel. As I mentioned previously in the chain of infection, we need to manage the environmental reservoir. And those reservoirs are, again, could become contaminated directly by the patient or the hands of healthcare worker. Generally, the number and types of microorganisms present on environmental surfaces are influenced by a number of factors, such as the number of people in the environment, the amount of activity in that environment, and the amount of moisture and the presence of materials capable of supporting microbial growth, and the rate of which organisms suspended in the air are removed, and the type of surfaces and orientation, whether they be a flat surface, a horizontal surface, or a vertical surface. So again, we need to look at those areas that are high touch within the environment, such as the overbed table, bed rails, furniture, call bell, light switches, doorknobs, etc. And we need to focus on eliminate or contain the reservoir of these agents, depopulating the environment or space by use of the proper products that are under the auspices of the Environmental Protection Agency, because we always indicate that it needs to be a EPA registered disinfectant that has been approved by the healthcare facility in order to interrupt the transmission of infection and also protect the host, which is the patients, the visitors, or the healthcare worker, against infections and diseases. This graphic was taken from the CDC, and I like it because it kind of graphically represents what I've been just saying about the transmission of organisms through contaminated surfaces. We have a colonized or infected patient that could contaminate the surfaces around them. And these surfaces can act as a direct source of transmission to another patient, or indirectly through the contaminated hands of the healthcare personnel. So if you look at this also like the Swiss cheese model, where it says clean and disinfect, where the dotted lines around that, we want to stop transmission right there. We want to make sure that the holes in the Swiss cheese are not lined up such that the contaminants from the surfaces then go on to the healthcare worker hands, to the susceptible patients, and hereby colonizing or infecting the patients. So the key focus here is to clean and disinfect that contaminated surface before it can go on to contaminating the hands of the healthcare personnel or that susceptible patient. We're all well aware that organisms can survive for lengths of time on environmental surfaces. This particular graphic shows the lifespan of organisms on surfaces such as the Clostridioides, Staphylococcus aureus, and you see that it can range anywhere from days to months. And so that is why, going back to the previous slide, where it's important that we do a proper job of cleaning and disinfecting those surfaces. We also have viruses that can survive from days to weeks to months on surfaces as well. For example, the SARS-CoV-2 virus can survive on surfaces up to 5 days. And the Candida auris, that new fungus that I told you that has been recognized and has caused multiple outbreaks, can survive on surfaces for 14 days. And you'll see HIV greater than 7 days. Hepatitis A virus can be hours up to at least 60 days. So again, very important that we realize that various bacteria, various viruses can survive on surfaces from hours to days to weeks and months. So moving on to our next objective is to discuss the various products that are available to us to use for cleaning and disinfection of environmental surfaces. And there are adjunct technologies and products that are assisting with raising the bar from those other practices that we normally use. There have been significant improvements, according to Philip Carlin, in disinfection and cleaning that can be achieved in hospitals without substantial added fiscal commitment. And this requires administrative leadership and institutional flexibility that is necessary to achieve success and sustainability by maintaining an ongoing programmatic commitment from the institution. So basically what this is saying is that when you use a structured approach that incorporates a simple, highly objective surface targeting method with repeated performance and feedback to environmental services personnel and administrative intervention, we should be able to succeed in managing our environment and sustain ongoing commitment to cleanliness in the environment as required, as I said earlier on, that the healthcare facility needs to maintain a clean and sanitary environment for our patients. One of the key features that we need to look at is our risk assessment of the environment. And what that involves is basic cleaning procedures based on the risk of pathogens transmission, such as the frequency, the method, and the process. That should also be a part of that assessment. And then we need to look at the function. What is the probability of contamination, the vulnerability of the patient to infection, and what is the potential for exposure? That is a high-touch surface versus a low-touch surface, and then rate whether it's a low, moderate, or a high risk to the patient. So again, that risk assessment is critical in order to develop your environmental services program, because what you might do in an office space may be completely different than what you do in a patient room. So that risk assessment is very important. There are many products that are available for environmental cleaning. First of all, they need to be registered through the Environmental Protection Agency. And that agency registered disinfectants that are used on surfaces where the FDA certifies or allows for product use that are deemed antiseptics that are used on patient's skin. So the FDA looks at what's being used on the patient's skin or on equipment that are used on patients, and then the EPA registered products that are used on environmental surfaces. And those products can be intermediate to low-level disinfectants, such as accelerated hydrogen peroxide, quaternary ammonium compounds, which we're normally used to referring to as quats, sodium hypochlorite, which is bleach, and also there are products that are peracetic acid hydrogen peroxide combinations. We also need to look at label claims, whether it's tuberculocidal, virucidal, or fungicidal, and whether or not we're going to use disinfectant wipes versus a method that requires dilution in a bucket or a bucket method. We need to be looking at the wet time, which should be 10 minutes or less as required by the EPA, but the actual contact time and wet time will be determined by the manufacturer. And the wet time will vary based on environmental conditions such as temperature, humidity, and airflow. So there may be a need, depending on the area, for possibly reapplying that disinfectant. So the key here is that you need to follow the manufacturer's instructions for that particular product. Care should also be taken in selecting cleaning implements. What is the impact of laundering versus use of a disposable material for cleaning, such as a microfiber cloth or a sponge cloth or a cotton cloth? So we need to look at how those materials will impact the disinfectant product that is being used. So it's really important that we are aware, again, of what the manufacturer's instructions say. One of the key things that need to be addressed, and again, I've shared there the graphic from the CDC, we need to focus on the basics and the thoroughness of cleaning and disinfection, because if we don't have the basics down, we can't jump to higher technology to replace the bad behavior that led us into the issues that we may face from poor environmental cleaning and disinfection. So technology is not necessarily the solution for the change that is needed in behavior. How hard will you work to manually clean the environment when your cleaning will be followed by technology? Especially when there could be issues with you need the room now if your emergency department is backing up and flow is being affected from the emergency department up to the patient care unit, or if you've got a lot of patients in your outpatient waiting room that need to be getting into an exam room. So one of the things that I notice in my practice is that when we are rushed, we tend to take shortcuts. So it's really important that you focus on slowing down and do the right practices, because that will eliminate the risk for outbreaks and possibility of patient getting an HAI or an MDRO from the environment. So we need to hardwire the basics by the use of checklists, making sure that we are cleaning from low contact to high contact surfaces, as you see in the graphic here from CDC, where we go from shared and common surfaces to item touched by the patient, and then to those areas that are high touch around the patient. We need to follow the manufacturer's instructions for use and maintain the wet contact time. Do not dry the surface. Let the surface dry just by being wet and then being in the air, so that the drying takes place naturally. And we need to do direct observations of the cleaning practices in the environment, and then do some monitoring around the cleaning and providing feedback of what we see from direct observation and monitoring. And once we've got that hardwired, then if we're still having concerns, then we can look at some of the newer technologies referred to as no-touch technologies. And some of those no-touch technologies include ultraviolet light devices. We also have hydrogen peroxide systems that are vaporized, mist, or dry. There are also now self-disinfecting surfaces that are made from copper alloys, and they're meant to kill microbes on contact. But again, if you're not able to reduce the bioburden on these surfaces and cleaning, pre-cleaning prior to use of these no-touch technologies, then we may be doing a disservice to our patients. This is a publication from Curtis Donsky that looks at no-touch technologies, the arguments for and against. And any technologies will have advantages and disadvantages. And again, some of these that are outlined here are the effectiveness in reducing healthcare-associated pathogens on surfaces. It has been proven that it's effective to do that. It is effective at reducing residual contamination on surfaces. And again, the efficacy of the decontamination cycles are not dependent on the compliance by EVS personnel. There's less issues with materials compatibility, requires a few minutes to initiate the cycle and to remove the equipment after the cycle is finished. And there are trials that have shown that used in addition to standard cleaning methods, it's been effective at reducing healthcare-associated pathogens and reducing hospital-wide C. difficile infections and VRE. But some of the arguments against these no-touch technologies is that, number one, they've seen similar reductions could be achieved by improving standard cleaning and disinfection methods, which is what I was referring to as emphasizing the importance of basics. And that residual contaminations of surfaces is also not uncommon after use of no-touch devices. And we need to look at effective implementation to ensure these devices are used and used correctly per ongoing monitoring and feedback. And also disinfectants with better material compatibility than traditional bleach products are now available to be used for organisms such as C. difficile. And there are some quasi-experimental studies that provide low quality evidence and are subject to bias because positive studies are more likely to be published. So again, CDC guidelines at this time are not promoting the use of these technologies for prevention of Clostridium difficile. So again, I would recommend referring to this publication by Donsky, and if you're considering any of these technologies, make sure you do your homework, and go along with that is conducting a risk assessment, as was implied earlier, in order to determine whether or not this is where you want to go as a healthcare institution. There have been some studies done, as I referenced earlier, with regard to no-touch technologies. And one of those studies is what's referred to as the Better Disinfection Study. This was a multi-center study that involved 9 hospitals in the southeastern United States in a randomized trial. And this study looked at, again, environmental cleaning and the impact of various methods around the environmental cleaning of the surfaces. What they did was they conducted, as I said, a randomized control trial, and they looked at room disinfection with 4 different strategies, and then they measured compliance with the disinfection strategy and the barriers to implementation and the perceptions of nurse managers and environmental services personnel. And what they found, that implementation of these disinfection methods where they use UV disinfection devices provided some challenges. And this included the time pressures from bed control personnel, efficient room identification, and the negative perception of nurses and managers as it relates to discharge volumes. In the course of the study, though, they did find that the implementation of enhanced terminal cleaning and disinfection strategies using UV devices required recognition and mitigation of two key barriers. Number one was the timely and accurate identification of rooms that would benefit from enhanced terminal disinfection, meaning that rooms where patients may have been on precautions such as contact precautions. Some facilities may refer to it as special contact precautions, where you might have patients with, for example, MRSA or VRE or some other resistant microorganism, and overcoming time constraints to allow EVS cleaning staff sufficient time to properly deploy enhanced terminal disinfection methods. So it's really important that we address the barriers before we throw the baby out with the bathwater, so to speak. So again, when we are looking at implementing some of these technologies, it is really important that we do our homework, that we look at what we're trying to achieve and how we are going to achieve it, and include those individuals that could be impacted by the implementation of any new strategies for managing cleanliness of the environment. There was another study that was done and published in the American Journal of Infection Control. This study looked at disinfection of non-critical medical equipment using hydrogen peroxide dry mist as an adjunctive method. And what this study looked at was manual disinfection of medical devices and use disinfection methods of aerosolized hydrogen peroxide, as they felt that this might be a very promising adjunct method. And what they did was they wanted to assess the effectiveness of the dry mist hydrogen peroxide system on non-critical medical equipment. And so the authors found that though the hydrogen peroxide dry mist reduced bacterial burden on non-critical medical items, cleanliness of the included ready-to-use object was high and no pathogens were found before nebulization. The high hydrogen peroxide dry mist device did not increase patient safety in their setting. And I want to emphasize that in their setting, they did not see that benefit. So again, the bottom line here is you need to do your risk assessment, look at what you're trying to achieve, and also determine whether or not this will be an adjunct that you can implement with your organization. But again, you must include those individuals that will be impacted by implementation of any specific technology. And you need to look at allocation of resources, both fiscal and people, as part of that risk assessment. So let's move on to our next objective, which is looking at the methods that can be used to verify environmental cleanliness. Because cleanliness, as the expression goes, is in the eye of the beholder. There are many methods for, again, monitoring environmental cleaning. And this is a process improvement practice. We need to look at training and competency, inspection and verification, and then look at compliance and instructions and other items as listed. So when we talk training and competency, we're talking about simulations, looking at high-touch surfaces, looking at the methods and the products that are used, and pictures go a long way in instruction and with training and making sure that we have competent individuals that are responsible for cleaning the environment. When we look at inspection and verification, we talk about monitoring high-touch surfaces before and after cleaning. We can use environmental markers or do direct observations. And again, some of these are easier to do than others, and we will get into those in a couple of slides. For compliance, we need to look at how compliant are we with our own written policies and procedures. If we are using contracted services, they should be meeting the healthcare facilities policies and procedures. We need to be able to evaluate the ability of the equipment to be properly cleaned prior to purchase and then putting it into use. Because again, after you've purchased and start using, it's no time to say, this product is not to be used on this surface. So when you're assessing products that you're purchasing, make sure that you are looking at the manufacturer's instructions for use related to dilution, contact time, and storage. Because the whole point of everything we do is to make sure that surface is clean and hygienically presentable and will not cause transmission to our vulnerable population, our patients. We need to also insert here that hand hygiene is all part and parcel of your compliance with environmental cleaning, because again, it is well known that hands can be indirect transmitters of pathogens picked up from environmental services. So we need to be monitoring and reporting there as well. We need to be using proper personal protective equipment and monitoring and reporting back. There is no point in monitoring if we are not providing feedback to those that are being monitored, and that we are cleaning surfaces from clean to dirty and not going back and forth and crossing over and recontaminating previously cleaned and disinfected surfaces. So let's look at the various ways that we can monitor environmental cleaning of surfaces. Some believe that just looking at a surface, and if it looks clean, then it must be clean. Just like we'll look at our hands and go, they look clean, so they must be clean. But again, we need to realize that the bugs are smarter than us. We can see the MRSA or VRE or the Candida auris or the spores of Clostridium difficile. So we need to look past just, it looks clean. There are those even who would say that, well, it smells clean, so it must be clean. But again, that depends on how the product has been used. Was it properly diluted? Is it the timeline for the product? Has it expired? What type of material was used to apply the chemicals that are used for disinfectant to the surface? So again, we need to be a little bit more questioning of how we are doing monitoring for cleaning verification. So let's look at things we can do to assess cleaning and cleanliness. The methods for assessing cleaning practices, we have direct performance observation, visual assessment and inspection, and fluorescent markers. Methods for assessing the level of cleanliness involve measuring residual bioburden, such as using ATP, which is adenosine triphosphate. And again, none of these are going to tell you what organisms are present on the surface. They just tell you that something on the surface has not been removed. And bacterial culture of the surface itself using a swab or a contact auger plate method, you can use that to say, I have this organism present on the surface, if you're willing to go the next step of identifying the organisms that are present on those surfaces. For cleaning practices, we can do direct performance observations by monitoring the caregivers, the healthcare workers that are responsible for cleaning those surfaces. But we also need to provide them with a standard, structured observation using checklists that are specific to the individual patient care areas, and rate the effectiveness of the cleaning staff by adherence to those standard operating procedures, such as identifying the number of steps that were performed correctly. And again, there are advantages and disadvantages to the direct performance observation. It's usually used for large areas such as units and wards. It's very easy to implement. You can benchmark. It doesn't cost a lot of money, and it allows for immediate and direct feedback to those staff and encourages cleaning staff engagement and input and identified gaps. Some of the disadvantages, it can be subjective and labor intensive. And if the EVS personnel know that they're being watched, they may do a better job, which is that Hawthorne bias, more of an assessment of knowledge than actual practice. So it does not assess or correlate to bioburden. For visual assessments, the observers check the cleanliness of items, such as using that white gloves test, quote unquote. Some of the advantages here that you can use it no matter where you are in your healthcare facility, or you can use it on units and wards. It's easy to implement. You can benchmark. It's inexpensive, and it does allow you to provide immediate feedback to the individual healthcare or EVS personnel. Some of the disadvantages are the feedback is delayed because it's dependent on the method that is used to compile the results. It is subjective and based on individual determination of dust and debris levels, and it does not assess or correlate to bioburden. For assessing cleaning practices, we have fluorescent markers, and we use fluorescent markers in my healthcare facility. And basically what it is, it's a tracing agent that marks predetermined items or surfaces before the EVS personnel does the cleaning. And trained observers using ultraviolet light or enzymatic detector to determine if any of those tracing agents is left behind after cleaning and disinfection. And these items and surfaces still show trace agents are then counted and scored, if not as to whether or not it was completely or partially cleaned or not at all. There are advantages and disadvantages here as well. It's quick, it's objective, it's inexpensive. You can get immediate feedback on performance with minimal training required to perform, and you can do benchmarking. However, it's qualitative, does not assess or correlate to bioburden. It's labor intensive as you're required to mark before and check after cleaning. And there are some difficulties in documenting in terms of removal, depending on the surface type, and it is time intensive. And again, it varies on the frequency and objects to prevent monitoring systems to become known, meaning that personnel might say, oh yeah, they always mark this spot, so I'm going to do a better job over here as compared to another site. There's been studies done that evaluated the fluorescent gel markers. Rock et al. Did a systematic evaluation of the fluorescent gel markers applied to high-touch surfaces. And what they found was that removal rates were around 60% for metered applications and 64% for the generic cotton swab. And so they found that removal interpretation was more consistent with a metered application, 83% versus 50% not removed. So it is possible due to less varied application and more adhesive gel, and the reference is there for you. Mayer et al. Also did an assessment of surface cleaning practices using UV marker technology and the extent to which the technology can help improve cleaning audits and practices. Using these markers, they found on the average that 63% of surfaces were appropriately cleaned. And so training, staffing, and time constraint may have played a role in some of the low cleaning rates, but overall, they thought that the UV markers can play a key role in revealing deficiencies in cleaning practices and help raise the awareness of these deficiencies and help to improve cleaning practices. So again, there are advantages and disadvantages, but again, you need to determine the methods that you want to use and what level of compliance or what level of acceptance that you are willing to tolerate. And another method for using to assess level of cleanliness is the ATP bioluminescence. What the ATP does is measure the residual organic soil on a surface, and it detection indicates that organic material, whether it be microbial or biologic, is present on an object or surface, and it provides a quantitative result that corresponds to the amount of organic material. As an infection preventionist, I've used this as a way of just spot checking environmental cleanliness through my healthcare facility. The objects are swabbed after cleaning with an ATP swab that are then measured in a luminometer. The advantages for a product like this is quick and convenient. You get immediate feedback, and it's amazing when you give feedback to the healthcare worker or the EVS personnel, how they react when something appears clean to their eyes and when they get the result from the ATP monitoring. It requires minimal training, and also it's more objective and quantitative at measuring overall cleanliness. It is a little more expensive and does require some specialized equipment such as the luminometer, and the benchmark is variable based on the luminometer scale. So it's really important that you follow the manufacturer's instructions because they're not all the same. So it's really important that, again, you look at the product, you follow the instructions, and then interpret the results based on the manufacturer's instructions. And the products that are used are going to be manufacturer specific. So that you take the swab from the tube and you swab the surface, and then you place the swab back in the tube and agitate per the manufacturer's instructions, and then you place it in the luminometer, and then you get a display on the screen of the luminometer in relative light units, or RLU. And then the accepted is usually around less than 150 is what we're using at our facility. Now, there have been studies done to assess the correlation between ATP concentration and bacterial bioburden. Here is a study that was done over a period of months where surfaces in occupied patients' room were at a tertiary care healthcare facility were sampled using two environmental cleaning assessment methods. One was the ATP and the other was bacterial bioburden in colony forming units. And the results are shown there on the table, but the study findings suggested that there was a correlation that existed between ATP concentration and bacterial bioburden, and they generally support ATP technology manufacturer recommendations for cutoff values. And despite the relatively modest discriminative ability this technology may serve as a useful proxy for cleanliness. So again, the manufacturer's product that you use may have a different cutoff point. So it's important that you look at the cutoff point and use that for what you consider, quote unquote, clean and what's considered not clean with relation to bioburden that might be on that surface. And finally, when we look at cleanliness assessment, we can do environmental cultures, which is a direct measurement of levels of microbial contamination after cleaning. Generally, it's not recommended unless there is questions that remain related to persistence of organisms on the environment or the effectiveness of cleaning. Swabbing can indicate the presence of a specific bacteria on a surface or a cleaning, or you can use contact auger plates known as Rodac to show the level of bacterial contamination on an area such as a large flat surface. In general, CDC does not normally recommend CDC environmental sampling unless you are doing something maybe for educational purposes. But that is a level 1B recommendation that do not conduct random unidirected microbial sampling of air, water, or environmental surfaces. When indicated, you can do sampling as part of an epidemiologic investigation or during assessment of hazardous environmental conditions to detect contamination and verify abatement of hazards. And again, you want to limit microbial sampling for quality assurance purposes. And again, such as biological monitoring of sterilizers, monthly cultures of water and dialysate. So you want to use those type of sampling for those methods rather than for the environment per se. So this graphic is from the CDC again, and I like it because it gives you kind of a structured approach to how to do this. Integrate EVS as part of that approach, do education and training, proper product selection, standardized protocols, monitoring for adherence, and providing feedback. And observe, audit, or monitor those surfaces and use cleaning verification methods and provide feedback and recommendation to key stakeholders, and use back to basics education and do a risk assessment on the role of technology. In summary then, the environment plays a key role in disease transmission, and patients are at risk for acquiring microorganisms from the environment, and accreditation agencies such as the Joint Commissions and have to meet the CMS conditions of participation, where we are providing a clean and sanitary environment for our patients. The environmental services needs to be partnering with infection prevention, and it's a necessary collaboration for reducing the risk of transmission. And multiple studies have demonstrated the role of the environment in disease transmission and the role of thorough cleaning and disinfection. A program should be in place not only to address environmental cleaning and disinfection, but also monitoring of the cleanliness. Technologies are an adjunct to cleaning and disinfection of the environment and must be assessed in a systematic manner to weigh the cost versus benefit, because the bottom line of all of this is to determine how clean is clean and what level of cleanliness are you willing to accept in your environment. Thank you.
Well, thank you, Jackie, for providing great takeaways for environmental cleaning and disinfection. A lot of great information. The audit stuff is something I'm definitely going to use in the future. So if you have additional questions you'd like to ask Jackie, unfortunately, we are out of time, but her contact information can be found in the speaker bio tool in the lower right-hand corner of your screen. There will be a short 15-minute break before the next session. And just as a reminder, you can access the CE survey and certificate by visiting beyondclean.net/virtual events, and you will be automatically transferred to that survey page after the conference. All of today's sessions will be available on demand to share and view after today's live event has concluded. Thank you again for joining us today, and we'll see you in the next session.